Hello guys, hope you're all doing well. In this video, we are going to discuss about physiology of labor. See, basically, physiology of labor can be learnt in 4 phases. Okay, so phase 1 is uterine quiescence. Phase 2 is the preparatory phase for labor, or there is activation of labor. Phase 3 is where the stimulation for labor begins, okay, and phase 4 is known as puerperium or uterine involution. Okay, see, you shouldn't confuse this physiology of labor where we are studying about the phases and the stages of labor. Stages of labor is different, phases of labor in physiology of labor is different. Clear? Yes. Now, we will see the first phase, phase 1, that is uterine quiescence. See, what is quiescence? Quiescence means it is silent. Okay, so it is silent, it is calm. That means there is no uterine activity at all. Okay, so normally if you see, there is 95% of the pregnancy state is going to be in this phase only. Okay, and also this phase starts even before implantation and it will continue till the next phase, that is the activation phase. Yes, so in this time, what is going to happen? See, here the uterus is going to have extensive changes. Okay, it is going to go for hypertrophy, it is going to enlarge in size, the vasculature is going to increase. All these changes are going to happen, but remember, the quiescence means it is not going to contract. It is going to remain silent. Okay, so that is the thing. So uterus undergoes extensive changes. Okay, there is change in size, there is change in vascularity, and there is change in the myometrium also. So all these are happening because the uterus has to accommodate the fetus. Okay, so that is what happening here. Clear? Yes. And the next one is, you have to know the changes in the myometrium especially. So what is going to happen is, the myometrial cells undergo a phenotypic modification, okay, to a non-contractile state. That's why it is going to remain silent, okay, to a non-contractile state. Also, the uterine muscle is going to become unresponsive to the natural stimuli, okay. So, the uterine muscle becomes unresponsive to the natural stimuli. However, this is not that much silent. A minimal level intensity contractions, okay, or present in the myometrium, okay, and these are known as Braxton Hicks contractions, or in the later period of gestation, these contractions will be perceived by the women as false labor. Okay, so this is most commonly seen in a multiparous woman, and it is most commonly seen towards the end of pregnancy and this is not associated with any cervical changes. So, no cervical changes associated. Okay, but there will be hormones acting during this stage also, right? So, the hormones like estrogen and progesterone are going to act, but they will be acting through the intracellular receptors, okay? So, estrogen and progesterone will be acting anyhow through the intracellular receptors. What happens in the myometrial cell means the plasma membrane mediated receptors. Okay, so this is the myometrial cell. Here the plasma membrane mediated receptor mediated increase in cyclic AMP is seen, and this will be leading to production of cyclic GMP, okay, and that will be leading to the modification of myometrial cell and ion channels. Clear? Now, I have to discuss about uterine decidua. What happens in the uterine decidua is nothing but the endometrium of the uterus in pregnancy, right? So, what is going to happen here is there is suppression of the synthesis of prostaglandins and prostaglandins F2 alpha, okay? So, these are suppressed, these are not produced anymore, clear? Also, remember the fact, ideally for labor to progress, the suppression withdrawal should happen, then only labor will progress. Clear? Okay. Now, we will see about cervical changes or cervical remodeling. Okay. So, this is also going to happen in the phase 1. So, what happens is, it undergoes greater tissue compliance, but in this stage, it is going to be unyielding. Okay. It is not going to open up at this stage, okay, sorry, at this phase. Then the maintenance, so this changes that is happening in the cervix is very important, so that the pregnancy will be carried till term, okay. But even then, there will be some structural changes. Which is the major structural protein in the cervix? Yes, collagen, right? So, what happens is, there is breakdown of this collagen, okay. So, during term and labor, what happens is, due to this breakdown of the collagen makes the cervix more soft. Clear? Okay. Now, coming to phase 2. What is the second phase? Is the preparatory phase or the activation phase. So, preparatory phase or activation phase. So, what is happening in this phase? Definitely the quiescence has to be stopped. Okay, so that is the prior thing that is happening in this stage. So, myometrial quiescence of phase 1 has to be stopped. Then, this awakening or activation usually happens in the last few weeks of the pregnancy. Suppose if these changes are happening before term, that is before 37 weeks of gestational age, then it will lead to preterm labor. Okay. Suppose if they are delayed means, then it will be known as delayed labor. Okay. Now, we will see the changes what are going to happen. Okay. So, first one is myometrial changes. There is increased expression of CAPs, that is contractile associated proteins in the myometrium. So, this will increase the responsiveness to the uterotonics. Then, there will be formation of lower uterine segment. Okay. So, formation of lower uterine segment. From which it is formed? It is formed from the isthmus. So, after this lower segment is formed, there is a differential expression of the contractile associated protein receptors as well as the prostaglandin receptors between the upper segment and lower segment of the uterus. Okay. So, differential expression of the prostaglandin receptors and contractile associated protein receptors in the upper and lower segments. And this is the stage where lightening is going to occur. Okay. What is lightening? As the fetal head is going to engage into the maternal pelvis, the pressure that is given by the fundus in the respiratory system, repeating. This is the phase when lightening is also going to occur. So, what is lightening? When the fetal head is going to engage into the maternal pelvis, the pressure that is given by the uterine fundus over the diaphragm is going to reduce, and at that time the mother will feel like she can breathe easily. Okay, so that is lightening. So, this is nothing but the descent of the fetal head through the pelvic inlet. Yes. Next one. Also remember, near term there is expression of one more protein called as HOXA13. Okay. So, that is seen in the lower segment, and this further induces CAP expression. Okay. And myometrial oxytocin receptors also rise, and the level of these receptors in term is greater than the preterm myometrium. Clear? Then what happens is myometrial gap junctions increased between the fibers, and because of this the electrical activity will be transmitted equally. We will see the cervical changes. See, cervical changes in the first phase, there was a stage of competence, right? So, it is going to make changes, but it is not going to be compliant enough to allow the fetus for delivery. But what is going to happen here is, there will be some changes that will be happening in the cervix that will be preparing the cervix to allow cervical dilatation and effacement for allowing delivery of the fetus, right? So, there is change of cervical state from state of competence to compliance. So, these cervical changes mainly include the connective tissue changes, okay, and this is called as cervical ripening. So, usually this begins weeks or days before labor, okay, and remember the fact that glycosaminoglycans are also increased, okay, and especially the glycosaminoglycan hyaluronate is increased. So, this is going to increase the viscoelasticity, then hydration, and it is also going to cause matrix disorganization. Clear? And remember that there is activation of neutrophils pro-inflammatory, M1 macrophages, and tissue repairing M2 macrophages. So, these are all going to cause collagen breakdown. Also, the prostaglandins are going to cause modification in the extracellular matrix structure. Okay. So, this will aid the ripening also. Okay. Especially which prostaglandins means it is the prostaglandin E2 or prostaglandin F2 alpha. Clear? And also if you see the lining of the cervical canal, especially the endocervical canal, it is going to be lined by the mucus secreting columnar as well as the stratified squamous epithelium. So, these cells are going to proliferate and they are going to form a tight junctional barrier. Okay, and this will prevent the ascent of the microbes. Okay, microbes cannot ascend through the endocervical canal. Okay, so this is the endocervical canal where you will be having the type of cells I have shown, mucus secreting columnar and stratified squamous epithelium. Okay, next is we have to see about the fetal contribution to posturation also in this phase. So, how the fetus is contributing simultaneously. So, fetal contribution to parturition. See, as the fetus is growing, it is going to stretch the uterine muscle, right? So, that time what is going to happen simultaneously, there is expression of the receptors like prostaglandin receptor, oxytocin receptors as well as connexin A3, okay? So, fetal growth will lead to uterine activation through stretch and it will cause expression of CAPs, oxytocin receptors as well as connexin. Okay, connexin proteins are nothing but the gap junction proteins. Okay, so this will be especially seen to happen early in case of multiple pregnancy or polyhydramnios. So that's why these states are at a high risk for preterm labor. Clear? Yes. Next one is we have to understand the fetal endocrine cascade also. So what's happening in the fetal endocrine cascade? See, 4 components are involved. Okay. First one is fetal hypothalamus, fetal pituitary, fetal adrenal, and this will also be orienting with the placenta, and all these orientation is considered to be a critical component for posturation. Okay. So, when there is premature activation of this cascade, it is going to result in preterm labor, and when it is not activated, it is going to result in postterm labor. Clear? So, what is going to happen is, first understand that what is the role of placenta. Placenta is going to produce a hormone called corticotropin releasing hormone in large amounts. Okay. So, this will be similar to that of the fetal and maternal CRH. Okay. But this is placental CRH. Okay. It is being produced by the placenta, but it is similar to both fetal and maternal CRH. Okay. So, what is the difference? Means normally CRH is produced from the hypothalamus of the mother as well as the fetus, right? So, what is going to happen is CRH, which is corticotropin releasing hormone, normally acts on the adrenal glands and produces cortisol, right? So this is normal. Now we have two types of CRH. One is hypothalamic CRH from the mother and the fetal hypothalamus, and the next one is a placental CRH, right? So what is going to happen is this hypothalamic CRH induces the production of cortisol, and a sufficient amount of cortisol will be giving a negative feedback on this hypothalamic CRH, okay? Whereas the placental CRH is going to get a positive feedback, okay? So this is going to get a positive feedback. Now what is going to happen is this maternal CRH, okay, is going to come in the amniotic fluid, and this will be seen increased during later gestational age. See, all these corticotropin releasing hormone will be holded by the corticotropin releasing hormone binding protein, okay, till term, okay. So in term what happens is this, the concentration of this binding protein will reduce and there will be free corticotropin releasing hormone. Clear? So in pregnancies where there is fetal stress like preeclampsia, the CRH is said to be increased, okay. So if you see CRH, corticotropin releasing hormone, it is going to cause so many actions, okay. So first one is it switches from the cyclic AMP formation to increased level of myometrial calcium levels, then it augments myometrial contractile force in response to prostaglandin F2 alpha, and then it stimulates the fetal adrenals for C19 synthesis, that is going to increase the substrate for placental aromatization. Clear? So three functions. Number one, there is increase in myometrial calcium levels. Number two, the augments the myometrial contractile force, okay, there is more response to the prostaglandin F2 alpha, and it stimulates the fetal adrenal glands also. So that will be used as a substrate for placental aromatization. Clear? Next one, we have to see about the fetal lung surfactant and platelet activating factor, okay. So it also helps in the fetal membrane senescence, okay, that is fetal membrane maturation. So fetal membrane senescence. So what happens is towards the end of the pregnancy, the fetal membranes will be going for a senescence and it will be resulting in a sterile inflammation. Sterile inflammation means no organism is going to come, but even then there is a inflammatory like reaction, and that is usually associated with the protein called as SASP, okay, that is senescence associated secretory phenotype. So Due to this, the inflammatory signals are produced and that will be weakening the fetal membranes. Also, some signals are produced at the level of decidua and myometrium also, that will be inducing parturition. Okay. So, signals activated in the decidua and myometrium that initiates parturition. Clear? So, this thing you have to keep in mind. And next one is, we are going to discuss about the phase 3. What is phase 3? It is stimulation. So, when it is stimulated, what happens? Labor is going to happen, right? So, it is all about labor here. Okay. So, we know there are 3 stages of labor. Okay. Obviously, we have a 4th stage also, but for now I am going to discuss about the 3 stages. So, first stage is from the stage of cervical effacement and dilatation. Second stage is the stage of fetal expulsion. And yes, obviously the third stage is going to be, what will be remaining? It is going to be the stage of placental separation and expulsion. Clear? Okay. Now, we will see about the first stage. So, if we see about the first stage, we will talk about the uterine labor contractions first. Okay. So, uterine labor contractions. So, what these contractions are going to do? See, normally, if we take, this is the pregnant uterus. Okay, I am not drawing that much bigger, but just imagine if this is the pregnant uterus and there is a cervix over here, what is going to be there at the end of the cervix? There is going to be a mucus plug, right? So, due to the contractions of the uterus, what is going to happen is this mucus plug is going to be lost, okay, and this time a few amount of show will be present, okay. So, that thing is known as bloody show, okay. And also we know most of the times the uterine contractions are going to be painful. Now, why these uterine contractions are painful? See, the reasons may include, number 1, there is hypoxia of the contracted myometrium. Second one, there is compression of the nerve ganglia, okay. Compression of the nerve ganglia in the cervix and lower uterus. And number 3, there is cervical stretching because of the uterine contraction. Do you accept that? Yes. Now, this cervical stretching is going to be caused naturally due to the contractions, but sometimes we can even cause a mechanical stretching of the cervix, and this will be acting vice versa. So, this will be going to produce the uterine contractions now. Clear? So, this reflex is known as, yes, very good, it is Ferguson reflex. Okay, sorry, it is Ferguson reflex. Clear? Okay. And also remember, when you are manipulating the cervix and you are stripping the fetal membranes, that will be resulting in increased level of prostaglandin F2 alpha metabolites. Okay. So that will be causing contraction of the smooth muscle. Also, one more point that is going to cause pain is there is stretching of the peritoneum over the fundus of uterus. Okay? Yes. Now we will see what are the changes that is going to take place in the upper segment of the uterus and the lower segment of the uterus. Okay? So if we take the upper segment and the lower segment. See, remember, upper segment is going to be much firm, whereas lower segment is going to be softer. And upper segment, there is continuous contraction and retraction happening, whereas in the lower segment, there is more distension. Yes? And then the upper segment is the segment which is going to be active throughout the labor. Okay? The lower segment is going to remain only passive. So the upper segment, as it is going to contract, it is going to become much thicker. Okay? So this is thickened, whereas the lower segment is going to be thinned out. Okay? So normally, okay, if you see the picture, so this is the, imagine this is the uterus. Okay? So this is the cervical point, okay, and let's take this as the isthmus where the lower segment is formed. So this region will be forming the lower segment and this region will be forming the upper segment. This is going to get thickened, yes, and this region has thinned out now, right? So this differentiating point between the two things, okay, so this will be seen as a retraction ring, okay, so that is known as physiological retraction ring. In conditions when the lower uterine segment is extremely thinned out, this ring becomes more prominent and this is called as pathological retraction ring, or it has a special name, that is Bandel's ring. Okay. So this is the picture for better understanding of these terms. So this is the normal shape of the abdomen. Okay. So you are able to see a small depression here, but it is not that much significant, right? So I'll just mark it like that. Okay. So here, okay, that is not that much significant. Whereas if you see over here, there is the upper segment and distended lower uterine segment are separately seen with some deeper depression. Okay. So this is known as a Bandel's ring. Now what about the abdominal muscles? Okay, how they are going to help? See, abdominal muscles are very important because one of the important factor that will be helping in fetal expulsion by the mother is the increase in intra-abdominal pressure. Contraction of the intra-abdominal muscles along with some forced respiratory efforts that will be helping in expulsion of the fetus by the mother is known as pushing. Okay. So during that time there is action in the muscles as well as there is some forced respiratory efforts. Okay. Yes. Now we'll see what are the changes that is going to take place in the cervix. So when we take cervix, in this phase there are two changes. Okay. Number one is effacement or taking up of the cervix. Then number two is dilatation that is up to 10 centimeter. Clear? So, how this taking up occurs, or what does this taking up means? Taking up simply means the sum of the length of the cervix is going to be drawn into the lower segment, because for the formation of the lower segment, not only the isthmus region is going to be used up during labor, some part of the cervix is also going to be taken up for the formation of lower segment. Can you understand? Yes. So, that is effacement clinically manifests as shortening of cervical canal from 3 centimeter length to an opening, okay, mere opening with paper thin ridges. Okay, so this term is very important. This is what you feel during your pervaginal examination also. Once the cervix is completely thin, we'll be assuming that the effacement has been taken up. Okay. Another change that is going to happen in the cervix is cervical dilatation. So, whenever the upper uterine segment is going to contract, the lower uterine segment under the cervix are less resistant to this contraction, and they are going to give away. Okay, slowly they are going to open up. Okay, so that is dilatation, and there will be a centrifugal force that will be acting from the uterus in all the walls of the uterus. Okay, so what is about dilatation? That is the centrifugal pull over the walls of uterus from the walls of uterus. Okay, pull from the walls of the uterus leads to cervical dilatation. Okay, so when the cervical dilatation is happening, what is the immediate next thing you will see? The fetal membranes. So this is a pic where there is no effacement or dilatation. Okay, you are able to see the cervix, right? It is completely closed. Okay, but what is going to happen in later stages is this is going to open up slowly like this. Okay, and the immediate thing you are going to see is the membranes. Okay, so these membranes now will bulge out like this. Okay, and this will be known as the forebag or bag of membranes. Clear? Yes. Now we'll see what are the changes that is going to happen in the second stage. So in the second stage, it is very important to note when the engagement is going to happen. Okay, so engagement of the fetal head happens in a nulliparous before labor itself, whereas in multiparous the engagement happens only when labor begins. Okay, and speed of the descent of fetal head is maximum during the second stage. Speed of fetal descent is maximum. Okay, and here it descends and reaches the pelvic floor. And in the pelvic floor, the biochemical properties are also changed. Okay, biochemical properties are also changed. That means there is an alteration of extracellular matrix structure and composition. And among the pelvic floor muscles, it is the levator ani which is going to have a maximum change, and if you see, there is thinning of the perineum, especially the center of the perineum is going to thin out. Okay, so it changes from 5 centimeter thickness to 1 centimeter thickness, and then anus also becomes markedly dilated, and it presents as an opening, so that you will be able to see that the anterior rectal wall will be prolapsing through the opening. Okay, opening through which the anterior rectal wall bulges. Clear? Yes. We will see the final thing, that is the third stage, that is delivery of the placenta and membranes. So, what happens after delivery is, there is diminution of the size of the uterus, and there is an decrease in the placental implantation site in the uterus. So, because of this contraction and diminution in the placental site area, the placental separation occurs. Okay, and which is the layer at which the placental separation is going to occur? It occurs at the layer of decidua spongiosa. Now, there is formation of a hematoma at the placenta and decidua interface, and the membranes also will get separated from the uterus and they will be thrown into folds. So, this placenta and the membranes together will be coming out through either the Sulci method or the Duncan's method. Okay, so that's why soon after the delivery we have to check whether all the fetal membranes have come out and all the cotyledons of the placenta are also seen. You have to examine for the placenta as well as the fetal membranes. Clear? Yes. Now, I just want to discuss about some of the uterotonics in parturition. So, uterotonics that are used in parturition. Very important one is oxytocin. Okay. So, oxytocin, if you take this as a nonapeptide, this is synthesized in the magnocellular neurons in the hypothalamus. Okay, in the magnocellular neurons in hypothalamus, especially the supraoptic and paraventricular neurons, and this will be carried out through the posterior pituitary via a carrier protein called neurophysin. Okay. So, it is synthesized in the hypothalamus, whereas it is stored in the posterior pituitary. Okay. So, this is very important. Clear? Okay. Now, we will see what is the importance of this hormone here. Okay. So, we will see the importance of oxytocin now. We already know towards the end of the gestation, there is increase in oxytocin receptors in the myometrium. Yes. So, towards the end of gestation, there is increased oxytocin receptors in the myometrium as well as in the decidua. Okay, and in the decidua. Not only this, oxytocin is directly synthesized in the decidua, placenta and the extra embryonic fetal membranes. Okay. So, you will be seeing an increased oxytocin levels during second stage of labor, early puerperium and during breastfeeding. Yes. Now, we will see the next hormone, that is important one, prostaglandins. See, the levels are seen increased in the maternal plasma, maternal urine and amniotic fluid. And we already know the receptors of prostaglandin E2 and prostaglandin F2 alpha are increasingly expressed in the uterus as well as cervix. So, that is why when you administer prostaglandins through any of the routes, it is going to cause miscarriage. Okay. So, administration of prostaglandins in early stage, okay, before natural labor commences, when you are administering that, either it can lead to early labor or it will lead to miscarriage. So, this will be acting at all gestational ages. Throughout the pregnancy, this will be acting, right? So, fetal membranes, placenta, decidua also produce prostaglandins. Primarily, it is prostaglandin E2, then it is prostaglandin F2 alpha. Clear? Yes. And two more things about endothelin. One, so this is produced in the myometrium in term gestations, then it induces the synthesis of other contractile proteins also, like prostaglandins, and it also increases the inflammatory mediators. Yes. And the next one is angiotensin 2. So, you have two types of receptors for angiotensin 2. Angiotensin receptor causes, one receptor is mostly expressed in the non-pregnant uterus, whereas angiotensin 2 receptor is expressed in the pregnant uterus, and definitely angiotensin is going to cause vasodilatation, okay, vasodilatation. Suppose there is decreased level of angiotensin, means then it is going to result in preeclampsia. Clear? And the phase 4 is puerperium. So, after 1 hour of delivery, the myometrium is going to be contracted, okay. So, it is going to be persistently contracted, okay. So, there is no relaxation or nothing, okay. So, for 1 hour after delivery, there is persistent contraction of the myometrium, and this will constrict or compress the large uterine vessels, and you will also be able to see thrombosis of the vessels also. So, everything is going to prevent PPH. Clear? So, with this, we are finishing this video. Until we meet in the next video, happy learning. Take care and bye-bye.